experience. Okay. I like to present my daily practice, not only the detection of the internal thoracic artery dissection. Okay. And at the beginning of the presentation, I briefly would like to show Japanese situation. This is how many percentage of off-pump CABG was performed in Japan. After 2004, more than 60% of the CABG was performed by off-pump all over Japan. Comparing to the syntax trial, it's very high number. And not only for the primary elective, but the redo or emergency cases, more than half of the cases were performed by off-pump. And the hospital mortality was only less than 1%, 0.82%. And also the stroke ratio is 0.75%. This is all over the Japan. And routinely, 73.8% institute in Japan, we perform transit time flow measurement. So in Japan, it's almost like a routine procedure. And especially for the ultrasonic echo assessment, 5% institutes are performed. And including SPY or other techniques, we perform intraoperative evaluation almost 90% in Japanese institutes. So recently, we introduced this very QC machines, and I like to show my daily practice. So before starting the coronary anastomosis, I always assess the target coronary evaluation, and then after anastomosis confirmation. So what can be seen by the EACTS system is this is an intramyocardial region. So you can imagine how much depth the coronary artery is located, and then if there is a septal perforator, you know, and if there is a calcium plaque, you can easily imagine that there is a calcium plaque. Okay, so. And recently, I changed a little bit, made a little bit of modification. I've started by the left side pictures. With the sonar part, I analyzed the result using a stabilizer. And sometimes I get difficulty to get a good picture. So recently, I always put the stabilizer, and with some kind of integrated probe, means on the operative field, I make this kind of, using the middle finger of the gloves, and cut the sonar part, and put the setting in that middle finger part and the sonar part, and ligate it, and make a integrated probe. And this is easy to get a good picture for not only the in front of the heart, but the back side of the heart. Okay. So this is a case of a 79-year-old male op-cab, full op-cab. And before starting the LAD anastomosis, I assessed here. This is a point of the myocardial of intramyocardium LAD, and this I can find the calcium plaque. And then my distally, the wall looks fine. So what can I see actually during the operation is the left view. So because I know the proximal part of the LAD is intramyocardially, I put deep stitches for the occlusion stitches for the myocardium, not to injure the coronary arteries. And then I cross over cutting the calcium plaque and the relatively normal distal wall. So, and finally I made a little bit longer only patch plasty, and as you see, for the proximal part of the anastomosis, the flow is cross-overing to the calcium to the proximal part or the distal part, and the transit time flow measurement shows 78 millimeter per minute good flow. And if you find a long calcified region like this, so scan first proximal LAD, and then middle, and the distally, and it is almost like you are And in the case of the mitral valve repair, you detect, get the picture from the transesophageal echocardiography, and then you reconstruct what was the real thing. And like this, I scan these areas of the LAD and make a picture of the LAD. And then in this case, I made a long onlay patchplasty for this case. And finally, I checked by using a color Doppler. And if you use this integrated probe, it is easy to assess the circumflex side areas of the coronary artery. Just put it, very easy. But if not, the sonar pathway slip away and the gel is going away. So this is easy way to get the pictures. And further, after the sequential anastomosis, I can check the configuration of the saphenous vein graft and also the flow. Okay. So how you detect the internal thoracic artery dissection? Okay. This is a case of the off-pump bypass, 66 years of male. During the anastomosis, I feel a little bit bad feeling about the anastomotic site. But after the anastomosis, it looks fine. And we checked the flow, 10 milliliter per minute. I thought it was unsatisfactory, but pulse index is 2.0 and diastolic flow is 65%. So what I do is we analyzed using the ultrasonic flow probe. So this is a longitudinal scanning view, and this is a transverse scanning view. It's almost like a dissection of the aorta. The dissection of the aorta was clearly shown. And then we revise the graft and get a real nice flow afterwards. And this was published in Circulation recently, and maybe you have that paper in your seat. Okay, and for the epiaortic scanning, if you scan the aorta, if there is a calcified aortic wall, you can get this kind of picture. And if it's a diffusely thickened atheromatous intima, you can find this kind of picture. And this is a soft plaque of the back wall of the aorta. It can't be detected by plain CT, but easily can be detected by using this kind of machine. Okay. This is an interesting case, 74 years old male, and he got a bilateral ITA graft 18 years ago. It's good functioning. And also, right coronary was 100% occlusion due to stent occlusion. But the problem was bilateral subclavian artery shows severe atherosclerosis. And the totally aorta is so much severely calcified. And he got esophagus cancer and need operation. So what our strategy was, for severe calcified of aorta, no cannulation site, we decided to go off cap. And proximal saphenous vein anastomosis using passport. So epi-aortic ultrasound scanning using VeriQC. And right reimplantation to proximal saphenous vein graft. Transit time flow measurement confirmation using VeriQC. And also to detect the distal right coronary artery, the EACTS to inferior wall using VeriQC. So this is this part of the aorta, calcification and soft plaque. And this is the only part, only limited spot was eligible for anastomosis. So it is like a pinpoint bombing of the using a passport. Successfully, we got the anastomosis. And then I checked the flow of the writer and put the shunt in it and checks the flow of the shunt, 40 millimeter per minute is okay. Then make a side-by-side anastomosis and cut down the writer, and then finally we get the flow of the 65 milliliter per minute. Okay, and then for the distal right coronary branches, from by the coronary angiography, we can't find any good arteries for the inferior wall. So I scanned it and find the posterior descending artery is clearly detected by using VeriQC. And easily we could find the right portion to anastomose the saphenous vein graft. And finally, we confirm the graft flow of Rita to ADD and saphenous vein to 4PD. The patient is good condition, finally. So there is another usefulness and potential efficacy in other cardiac procedures using this technique. So this is a case of the emergency case of acute aortic dissection. And so the echo showed, the CT shows the coronary artery disease is highly suspected, but because time is limited, the coronary angiogram was not performed. So we scanned intraoperatively of the LAD. There was a stenosis of the coronary artery. So we put a bypass on LAD. But on the other hand, on the right coronary, transverse scanning shows it's calcified wall, but it's patent. So we didn't do anything for the right side. This is another interesting case. For the coronary angiograms, the osteostenosis of the right coronary artery is highly suspected but uncertain. So I think this is a kind of pitfall of diagnosis. But the VeriQC clearly shows the mobile calcified plaque at the ostium of the right coronary artery. And see, there is a real restricted flow in the right coronary ostium. In this case, the patients required aortic valve replacement also. So we checked what the real thing is. So we could find the calcified plaque over there. So in this case, the combination of the aortic valve replacement, so it's okay. But if it's isolated coronary artery disease, this kind of evaluation is very helpful. Okay, and this is very interesting case of the coronary artery fistula with giant coronary aneurysms. So there is a coronary aneurysm and the tortuous arteries over there, and I want to ligate this fistula into the left ventricle. So, but on the surface of the heart, I couldn't find which is the right portion to ligate it. So, but the VeriQC shows clearly where the fistula into left ventricles. So, by minimal dissection, we could ligate that. Okay. So, as a daily practice, how to optimize the intraoperative decision making during CABG in combination with ultrasonography and transtimpanometer. For preoperative evaluation, target coronary, so intramyocardial or calcification. How was the caliber? Is that adequate? And then aortic wall, calcification or soft plaque or wall thickness. And then after the anastomosis, assess the graft quality by using a graft flow pattern. And I always use an occlusion test for the graft flow evaluation. What I mean here, for the off-pump procedure, for the proximal LAD and the distal LAD, I put a string for the occlusion. And soon after the anastomosis, I using a testing occlusion for the proximal part. Then if the flow increases, there must be some kind of competitive flow, but it's functionally okay. And so this kind of things I always do. And also, how about anastomotic configuration? And finally, internal thoracic artery okay. So then, including all this practice, the quality of the CABG must increase. So I would recommend just scan it. Thank you very much.